Regarding the natural mechanism, how this reflux, if it is going to get controlled, that is mainly based upon your lower esophageal sphincter competence. This lower esophageal sphincter, it is going to be there around 3 to 4 centimeter behind your GE junction, and next to that, it should be maintained by your phrenoesophageal ligament, and the angle of face is there to coordinate, and your reflex approaches will be prevented. What are the various pathophysiology? So if you're going to look into this picture, right from your esophagus into the gastrointestinal tract of your stomach, and once this mechanism, if it is going to disturb, the transient lower esophageal sphincter relaxation, if it is not going to work out properly, and your inadequacy of maintaining a proper tone of your lower esophageal sphincter, and once the patient is going to impact, starting from your oral cavity in your GI tract, you need to analyze how the patient is going to exhibit. If your oral sphincter is not going to, if your salivary secretion, if it is not going to clear off properly, if your duodenal reflux, if it is not going to augment properly, and once the patient, the gastric emptying time, if it is going to get prolonged, if your sphincter mechanism, if it is going to get failed out, there is high possibility for you to land up with the evidence of this GERD. That's how the pathophysiological mechanism concerning the basic approach. We should not forget the 4 major events. Your hypotensive lower esophageal sphincter, in case if you are going to land up with hiatus hernia, if you are going to grade the hiatus hernia as well, Hill's grading, there are various systems there based upon 1, 2, 3, 4. Once the patient is going to have evidence of hiatus hernia, your hypotensive lower esophageal sphincter, your relaxation, your transient lower esophageal sphincter relaxation has to be maintained at least around 10 seconds. If it's not going to be there, there is high possibility for this kind of patients to land up with evidence of GERD. So this is what the basic pathophysiology, that what I will discussed, and as we are going to progress, there's erosive and non-erosive. The common presentation, we should not forget, is mainly by heartburn, your regurgitation, as well as your burnings. Less common symptoms than what I've been discussed with you already. And what are the various conditions that mimics your GERD? So as I've been discussed, you should not forget certain basic things like your achalasia. If your lower esophageal sphincter, if it is going to fail to relax, it's nothing but a motility disorder. Based upon your modified Chicago, there is a huge variety of classifications there. So once the patient is going to land up with achalasia, the lower esophageal sphincter mechanics is not going to function properly, and your food is going to get staged. When you're going to do an endoscopy, it will be very difficult for you to progress the endoscope beyond the lower esophageal sphincter into your gastric cavity. So the patient will be having evidence of liquid stasis and a widely, prominently dilated esophagus, sometimes appearing like a mega esophagus, will be the prominent finding most of the time the patient is going to land up with evidence of achalasia. Achalasia is one common differential diagnosis that we should not miss out. Any patient who presented to us with evidence of dysphagia, but doesn't mean always the patient has to exhibit. Even early onset could not be having most of the present. When you're doing endoscopy, even without evidence of significant dysphagia, based upon dysphagia will be around grade 1, 2, 3, 4. Some patient will be having very grade 1 to 2 who doesn't manifest all the finding, classical picture of dysphagia. Even in that kind of patients, your endoscopy is going to have a yield. So any patients in the background who is having long-standing GERD, reflex symptoms, has to undergo endoscopy to look for evidence of dysphagia, achalasia cardia, and next to that it could be evidence of Barrett's esophagus. What do you mean by Barrett's? Nothing but very common terminology that you are frequently encountering. If your squamous epithelium of your esophagus, if it is going to get replaced by your columnar epithelium of your stomach, there is high possibility for this kind of patients to land up with evidence of Barrett. Among Barrett's, there are various classifications based upon your Prague classification system is there. Once a patient is going to land up with Barrett's, there is high propensity, high chances of this kind of patients to progress to adenocarcinoma. So we should not miss out all the basic differential diagnosis and rumination symptoms, psychological problems that will always superweight, because not only for your irritable bowel, which is always based upon your psychological intervention, but also your GERD, if the patient is going to have long-standing problems, that will be the female population, there might be high evidence for any rumination and other psychological disturbances to superweight. And eosinophilic esophagitis, even then it's very uncommon scenario, but there are once a eosinophils, if you are going to break a biopsy from your esophagus, there is more than 15 eosinophils if it is going to be there by high power field. That shows one of the differential diagnosis. Even then, if you are going to put the patient with PPI, H2 blockers, long-term therapy, which doesn't going to have a significant response, at that point of time, you need to analyze a clinical response, whether the patient is having allergic events, whether the patient is having evidence of eczema, atopic flu, dermatitis, rashes, all those points. So yet to full examination, even as a gastro, we should not forget the basics of examination when you're going to deal a patient with evidence of GERD. So GERD, the other point is like your functional esophageal syndrome. There are so many other common, like your functional heartburn, functional hypersensitivity syndrome, so many other complications, common scenarios is there, but that's out of the discussion right now. But what is the causes of GERD? If you're going to look into that, the main pathology what I will discuss, your hypotensive LDS, your swallow-induced relaxation of your lower esophageal sphincter, and your TLS if it is not going to augment properly, and once a patient is going to land up with evidence of hiatus hernia, and there is some evidence that Zollinger Ellison, we should not forget that if the patient is going to have continuous, if the acid secretion is not going to come down, if your gastrin levels, if it is going to be continuously high, there is high possibility for you to develop multiple complications like Zollinger Ellison. Zollinger Ellison, if you are going to do endoscopy, the patient might be having evidence of gastric polyps, worsening of secretion, persistent reflux, in which the dual dose PPI might be having a significant beneficial role to that kind of patients. As you all know, the common risk factors, obesity, we are not supposed to forget, sedentary lifestyle, if the patient is going to hiatus hernia, your abnormal diet and lifestyle modifications, tobacco, smoking, alcohol, all those things will be predisposing your consumption of a high fatty food, and even then some patients, some papers being reported to me, even if the patient is having high carbohydrate level, consuming peppermints and beverages, these are all the high possibility for you to land up with evidence of GERD. And diet and lifestyle modification is the most important thing for you to address if you are going to manage a patient with GERD. Apart from, diet and lifestyle modification itself will be controlling around 20% of the patients, and followed by, once a patient is going to land up with evidence of H2 blockers along with antacids, it will be taking on around 40 to 50%, and once a patient is going to start with PPI, it will be taking on almost around 50 to 70% of the patients, and if you're going to around dual dose PPI, there might be evidence that the patient is going to have response at a rate of around 90 to 100%. That's why the step up and step down regimen. So how long you are going to give, how to give, when do you suspect the patient with evidence of refractory GERD? These are all the symptoms you need to analyze when you are going to manage a patient with GERD. So alarming features, never we are supposed to forget any patient who have evidence of weight loss, which is going to be more than 10% over a period of time, and once the patient is going to evidence of dysphagia, you are going to suspect a mass in a GI tract, and once the patient is going to have evidence of persistent vomiting, if the patient is going to present with UGA bleed, always we are not supposed to forget, once the patient is having evidence of UGA bleed, hematemesis and melena, there could be a coexisting component, and persistent pain and development of anemia. Nutritional factors we are not supposed to forget, and odinophagia and dysphonia, all these complications, the alarming feature. Odinophagia, we are not supposed to forget, there is a possibility for candida in diabetic patients. They might be having a odinophagia, that might be having a precipitating factor of GERD. So all these pointers you need to analyze when you are going to manage a patient with GERD. Differential diagnosis, huge list is there. It could be because of peptic ulcer, which is always a co-mimicker of your GERD. But when you're going to start the patient, once you're going to diagnose a peptic ulcer, the characteristic presentation, either it is because of duodenal or gastric ulcer. Once a patient is going to have duodenal ulcer, the patient will be having the appetite. Once the patient is going to take a food, that pain is going to come down, but the pain will worsen if the patient is going to land up with evidence of gastric ulcer. So gastric ulcer is one of the most worsening even, because there are various classifications for that. That's nothing but Daintree-Johnson's evidence of gastric ulcer classification is there. So why I would like to point out, once a patient is going to diagnose with evidence of peptic ulcer, as we are looking into the etiological factor, the Helicobacter pylori is one common etiological trigger which you're not supposed to forget. So you need to initiate the basic regimen, but only when you are suspecting evidence of peptic ulcer, the role of H. pylori regimen is there. But once the management of GERD, if you are going to initiate the patient with H. pylori, it doesn't going to have any significant response in your erosion and all those things. So you need to clinically analyze to whom you are supposed to subject the patient with rapid urease test or any blood test, whatever the test which is going to use for H. pylori. And when you're going to eradicate the H. pylori regimen, you need to be cautious that eradication of H. pylori doesn't mean the patient reflux symptoms is going to come down. So reflux symptoms has to be addressed in a separate way rather than considering the treatment only for H. pylori when you're going to manage. And next to that, As I discussed, your various infections, your eosinophilic esophagitis and functional event, always you're not supposed to forget. And once the patient is going to have evidence of GA malignancies, it could be because of esophageal or squamous adeno, or it could be because of gastric malignancy. That's one of the most common trigger. We need to look into that, and various risk factors, a separate area of discussion. And apart from that, your respiratory, your cardiac, your extra GA symptoms, all these things could be a differential diagnosis for a GARD. But once you are able to come to the conclusion based upon your clinical presentation that this patient is having evidence of GERD, how are you going to approach? What are the basic investigations? What investigations needed? Or here in our Indian scenario, most of the patients directly going for medical management. But is it so? Once a patient is going for medical management or something else, and to whom you are going to subject. So upper GI endoscopy is very important to look for evidence of erosive esophagitis. That's what is called as Los Angeles, that I'll be showing in upcoming slides. So Los Angeles is 4 grading. Just remember that if you are going to have a multiple mucosal breaks, that means there is high possibility for you to land up with evidence of Los Angeles of stage 4 classification. And upper GI endoscopy is one of the definite pointer that we are supposed to do. Now barium swallow, not much of significance, and 24-hour pH metry is one of the gold standard to diagnose. What is this? If you can do 24-hour ambulatory pH monitoring, it could be because of wireless capsule or it could be because of impedance monitoring. So you need to place a transfer catheter inside your lower esophageal sphincter to assess the reflux episodes. That's what is called as D-Meester scoring system. So how much of reflux is going to happen? The number of reflux episodes when the patient is standing, when the patient is sitting, when the patient is in supine position at night. What is the symptom? How the patient is going to manifest? That is what is called as a reflux episode. If it is going to be more than 14, that is high possibility. This is the confirmatory clue for the patient is going to land up with evidence of GERD. And once a patient is going to diagnose with this kind of GERD, we need to look for evidence of acid exposure time. That is what is called as total acid, EAT. So what is this of the acid exposure time? If it is going to be more than 6, there is high possibility for you to land up with evidence of GERD. That's why the role of PPI, we need to maintain a pH of almost around more than 5.5 to 6 when you're going to manage a patient with GERD. So the upper GI endoscopy, the wireless capsule, now recent innovation like Bravo capsule monitoring, in which you are going to place a capsule through the electrode. That's how we are going to monitor that. And next to that, manometry. Once you are going to suspect evidence of your functional disorders, like your when you're going to suspect evidence of echinacea cardia, there is high possibility for you to look into a manometric clue. And always the basic investigation, the most important thing, impedance metry, 24-hour impedance pH monitoring is one of the gold standard to diagnose your gastroesophageal reflux. But who are all the patients recommended that GERD? If you are going to a worsening of events, even after 8 weeks of PPI, the patient's symptoms is not going to get improved. If the psychological factors, if it is going to get supervened, and next to that, if the patient is having duodenal reflux and non-acidic reflux, if you are going to have a persistent acidic as well as non-acidic, that when you are going to look into that. And apart from that, once a patient is going to plan for any surgical intervention, for example, if you are planning for any fundoplication or other procedures, at that point of juncture, we can try for this ambulatory pH monitoring for this kind of patient. Not for all, because it's a cumbersome, difficult procedure, will be carried out in very highly centers, but it's not being done everywhere. So once you're going to look into that, you can try for a diagnosis, but that's the gold standard to diagnose a GERD next to your endoscopic approach. And X-ray, barium, all those things will be yielding any significant picture if the patient is going to land up with any evidence of echinacea or any mass, everything is there. And apart from that, erosive esophagitis, that what have been discussed. When you're going to do an endoscopy, if you're going to see a mucosal break of more than 5 mm, which means it is being grade B. Once a mucosal break, if it is going to be less than 5 mm, it is grade A. And if it is going to be extensive involvement of your esophagus, if it is going to be more than 75% of circumference, if it is going to get involved, that means the patient is going to land up with evidence of grade D. Why I would like to point out this picture to you all, because the grade A and grade B will be very well responding to your H2 blockers. But once a patient is going to land up with the evidence of grade C and D, there is no role for H2 blockers. You need to consider with PPI, either single dose or double dose regimen of PPI, you are going to consider the esomeprazole or rabiprazole, whatever the molecule you are going to use. That is the main line of therapy. Once a patient is going to land up with the evidence of grade 3 to 4 Los Angeles of erosive esophagitis. So basic management, as I discussed with you all, diet and lifestyle with your basic PPI and other support. So non-erosive reflux disease is one of the common entity. Around 60 to 70, 50 to 60% of the population be exhibiting this kind of presentation. To them also we are going to initiate the patient with PPI support, and in case if it is not going to respond, this kind of patients to be subjected with a impedance metry and other other modalities to diagnose. This is the basic of, so Barrett's, as I what have been discussed. So coming mainly to the treatment guidelines. So once you are going to diagnose a GERD, how are you going to treat the patient? So that's the most important thing based upon the ACG task force guidelines. So what is the guideline they have mentioned? You need to take with diet and lifestyle that is going to take around 20%. What is the diet and lifestyle? So make sure your diet should be only 50% of your gastric capacity, and always you need to give a gap. Your nap time and your diet should be at least 2 to 3 hours a gap. Always you need to sleep in prone position, left lateral position rather than sleeping in supine or prone. And next to that, head and elevation is very important, and minimal diet, walking 45 minutes, 30 to 40 minutes of aerobic activities is important, and 4 to 6 hours of exercising in a week is very important if the patient is going to have evidence of obesity. All this, and diet modification, alcohol, smoking, your beverages, all those things you need to cut down. And based upon all those things, you are going to tackle your basic lifestyle modification. With this, you are going to improve presentation at least 20% of this case. And next to that, the next line of therapy always your antacids. There are many prescriptions for antacids. You can use your aluminum prescription, aluminum antacids. You can go for a magnesium hydroxide support, and all these things when you are going to use an alginate, you are going to target. How the mechanism of action? So once a patient is going to have evidence of persistent erosive events, if you want to subside the patient with evidence of acute substitution of symptoms, what are you going to consider? That's what is called alginate preparation. So within 3 to 6 hours, the effect is going to last. We can give 10 ml OD for around 4 to 5 times for the patient when you're going to subject. But how does it going to act? It is going to co-localizes in your GI tract. That is going to form a bond. What is called as, it is going to form it's going to inhibit your acid pocket by inhibiting the raft mechanism, by formation of your raft, which is going to co-localizes in your secretory canaliculus. So that's how the mechanism of your alginate preparation is going to be there. And there are more side effects. Bloating, some patients will exhibit diarrhea if you're going to use magnesium compounds. Some patients may exhibit constipation if you're going to use aluminum compounds. So always you should be very cautious. The effect is going to be short lasting, and it's not going to act on any evidence of erosion. So erosive esophagitis definitely will not be addressed. The clinical symptom most of the time will not going to respond if you're going to manage the patient only with alginate support. Next to that, H2 blockers. See, there are various H2 blockers are there. One is cimetidine, famotidine, nizatidine, now lafetidine is there in the market. You can give, but what is the role of H2 blockers? One important thing I want to discuss here, it is going to prevent your nocturnal acid breakthrough, which means most of the acid secretion is going to happen predominantly in the nocturnal hours. So when you're going to put the patient with PPI in the morning hours, and you're going to subject the patient with the H2 blocker in the night time, which is the high possibility for the patient to have more reflux episodes, that's the role of your H2 blockers. But there are some common adverse events. As you all well know, cimetidine may cause gynecomastia, not much of use. It is going to interact with your CYP your 450 system. Some drugs are going to interact with that. And next to that, some patients may exhibit evidence of hypertension. Some case reports are there, but not major adverse events which is going to happen with your H2 blockers when you're going to use, rather than when you're going to use PPI for a long time. But one common thing we are not supposed to forget, your tachyphylaxis. The terminology what is called as tachyphylaxis. The dose, if you're going to persist for a long time, the response of the patient is going to come down. So the tachyphylaxis is one common adverse event which is going to report with your H2 blockers. And Los Angeles erosive esophagitis of grade A as well as B, you are going to respond with H2 blocker. But once a patient is going to get into the trap of almost around grade C and D, there is no potential role of H2 blockers. Next very important area for me to take on a discussion is your PPI, proton pump inhibitor. What is this proton pump? It's nothing but hydrogen potassium ATPase which is going to get formed. There is a process what is called as a secretory canaliculus pathway, in which the acid secretion is going to get augmented in your gastric area, which is mainly through your parietal cells of your stomach. So once this acid secretion, what is going to happen? There is lot of hydrogen ions. It's going to get accumulated, replacing your potassium ions. Once hydrogen ions is going to accumulate, your pH is going to come down, your acidity is going to get increased. That's why the mechanism of this proton pump inhibitors is going to take on. It is going to irreversibly inhibit your hydrogen potassium ATPase. Once a patient, the irreversible inhibition, if it is going to get happen, what is going to happen? It is going to prevent more and more hydrogen ion formation. So it will be maintaining a pH of more than 5. Once the hydrogen ion formation, if it is going to come down, the next response will be your acid secretion is going to get inhibited. But the main problem for this PPI, we are all experienced with that. So when you are being reflux events, we are going to take PPI, but it will take a long time for this acid secretion. At least around 8 to 12 hours it will take. So immediate response is not going to be there, and sustained response is not going to be there. So it will take minimum 8 to 12 hours. That's one of the demerit when you are going to get used with your PPI. But once it's going to inhibit, it's going to irreversibly block, and it will take minimum another next 24 hours for this acid secretion to get augmented. So we are not supposed to forget, if you're going to use PPI, always we need to combine with H2 blockers if the patient is going to have evidence of worsening of reflux, that too evidence of erosive esophagitis are almost around grade 3 or 4 when you're going to manage. So PPI, you list is there, starting from your pantoprazole, omeprazole, and your esomeprazole, rabiprazole, you list are there. But my predominant brands will be going for esomeprazole or rabiprazole, because rabiprazole is also considered mainly for cardiac patients to prevent major acute coronary events, as you are well know, because PPI is one thing which is being reported with major acute coronary events when you are going to give clopidogrel. When you are going to give clopidogrel for a patient, there is high possibility for you to interact with CYP2A, 450 pathway. At that point of juncture, the clopidogrel drug dosage may be the efficacy is the second main potency, and will be a reasonable beneficial role when you are going to give esomeprazole, because rather than when you are going to give omeprazole or pantoprazole, the sustained mechanism of action for longer duration will be less, but in esomeprazole and rabiprazole definitely it's going to be more. Now the newer molecule like dexlansoprazole, which is going to be an enantiomer, and it is going to have a significant potential. Even elaprazole can be considered that, but the sustained reasonable benefit when you're going to combine your prokinetic with your PPI, they're definitely going to have a significant response. What is the role of prokinetics? The role of prokinetics is very important. As we all know, various mechanisms of action of prokinetic, one by domperidone, and next to is etopride, cisapride, and zinetopride, and so many molecules of the cisapride has already withdrawn from the market because of your cardiac events. And domperidone, as we are well known, has some multiple combinations day in and day out. Without domperidone, we are not going to live. And 10 milligrams twice daily we are going to use, but it will not cross your blood-brain barrier. But the domperidone, the sustained efficacy is not going to well established. There might be once a patient is going to land up with evidence of diabetic gastroparesis, if you are going to land up with the evidence of severe diurnal gastric reflux, and if your TLCR, if it is not going to be well maintained, and if you want to improve the tone of your lower esophageal sphincter, at that point of juncture, you need to go for the best prokinetic is nothing but etopride. So when you're going to consider etopride, now might be having a significant beneficial role for you. And next to that, we can consider zinetopride. That's another next potent molecule at a rate of 1 milligram thrice daily, or etopride at a rate of 50 milligram thrice daily. We can consider when you're going to manage. So either by D2 antagonist, or by acetylcholine stress antagonist, or by your H3 and H4 pathway, or the HD4 pathway, all this mechanism is going to get augmented when you're going to use your prokinetic. And apart from that, there are some other molecules like your transient lower esophageal sphincter relaxation inhibitors, like your baclofen, nothing but your GABA B agonists. If you're not going to have a significant response, if you're going to have a persistent hiccups, if the lower esophageal sphincter pressure is not going to be well maintained, at that point of juncture, you can give a short course of GABA B agonist. For example, your baclofen, now so many other molecules is there in the market, your mesogabalin, so many other things are there. But 5 to 20 milligrams for a period of time, around 4 weeks, when you're going to consider, we can try. But there are so many cardiac other safety profile is still not being much addressed. The neurotoxicity is being there. So at that point, no much of beneficial role for baclofen for TLCR inhibitor when you're going to consider. And apart from that, based upon these are all the medical management, newer molecules, so many new molecules like your potassium competitive blockers and your nocturnal acid breakthrough, that what I will discuss with your new molecules like lafidudine, your voraprazole, so many other things being tried in the market when you're going to manage, but that's all of the discussion. The main thing, esomeprazole or pantoprazole when you are going to manage. These are all the various drugs we should not forget. Advantages are already discussed. The refractory GERD is nothing much. So as I discussed already, if the patient is going to land up with the evidence of your GERD symptoms for more than 8 weeks, it's going to consider as refractory. And so before taking on the discussion of surgical intervention, we should not forget very important thing which is happening in the field of gastroenterology is your endoscopic intervention for this patient. What are the various endoscopic interventions being reported? That mainly by your radiofrequency ablation. If you are going to diagnose with Barrett's, you can do a radiofrequency ablation, and there are so many fundoplication procedures being available. That's what is called as transoral incisionless fundoplication. And strata, so many procedures, Muse, Stapler, and you're going to seal that area through endoscopy. The innovation on the field of gastroenterology has been dramatically progressed if you want to manage a patient with. And next to that, what is called arms. It is anti-reflux mucosectomy. So all the area, if it is going to target either your greater curvature of your stomach or the lesser curve, or in the lower esophageal junction, your sphincter, you are going to place a bead, a magnetic bead, a titanium core. There are so many innovations being developed. There are so many, in well advanced centers in gastroenterology, this kind of modality is being used to prevent if the patient is going to have evidence of refractory GERD. That's why the refractory GERD is a separate area of discussion, and rather than considering only GERD. So refractory GERD is another important potential area that we are not supposed to forget. Once a patient is having worsening of events, if the patient has reflux for more than 8 weeks of PPI, so always you need to look for any danger alarming picture before you are going to manage a patient with this kind of refractory GERD. Surgical options, if the patient is going to have long-standing, if the patient is going to have evidence of grade 3 to 4 hiatus hernia, at that point of junction, when you're going to consider 360-degree fundoplication, that's what is called as Nissen's fundoplication, we can try out, but now the innovation of endoscopic intervention has been progressed very high. This kind of surgical intervention has come in less in the field of gastroenterology. Next to that, your anterior fundoplication, your posterior fundoplication, like a thigh as well as toupee, so many fundoplication procedures that can be tried, and indications for surgery is very simple. If the medical therapy is not going to work out, if the patient is going to have any evidence of GE complications, like if you are always, you should not forget, once a patient is going to have evidence of GERD for long standing, if you're going to have a peptic ulcer problem, at that point of junction, you may develop a stricture in your esophagus. That is what is called as peptic stricture. That's one of the complex area to manage. It could be refractory or it could be recurrent. There are various definitions for the peptic stricture. Once you're going to diagnose, you need to manage, you need to dilate the tract either by your Savary-Gillard's dilator, or you need to go for multiple other newer modalities being tried. And if this nothing is going to work out, then you may try a stent and other placements. So why I would like to point out the innovations, the endoscopy has been grown so high in the field of gastroenterology when you are going to manage. So not all cases of GERD look to be simple. So before concluding, I would like to say one point. Look for the symptoms, analyze the patient in the proper way, and tackle the risk factors. Look for any alarming events, and to whom you are going to prescribe, and how are you going to do the endoscopic intervention, what is the finding you are going to analyze, and how are you going to counsel the patient for risk factors management. And serial follow-up is very important, and titration of dosage and guidance has to be done in a proper way. If you are going to do all these things properly, probably the GERD will be definitely well controlled in our scenario. With this, I'm happy to rest my presentation. Thank you all for patient listening. Any questions there, I'm happy to take on.
Your answer. Many patients respond well to PPI and propane. Once they stop, they get back the symptoms. How long we can keep on medically treating this?
So, in Indian scenario, apart from the literature, what they were mentioning, you are giving for years. Many patients are giving years of PPI, even multiple centers, even government centers, they are giving years of PPI. The one thing I forgot to mention in my discussion, PPI is one of the first molecules because the innovation, the complex, the adverse events of PPI, for example, funding, the development of funding gland polyp is very commonly reported. Even I have seen many patients with this funding gland polyp, post-PPI, zollinger and all those complications. And next to that, your renal injury, you are going to exhibit a more renal injury, and some patients are going to develop bone complications like osteoporosis, and there are many patients may exhibit hypomagnesemia, and there are some patient may exhibit your acute coronary events because of your clopidogrel and other drugs are not going to get impact well, and there are so much of adverse events is going to get reported. That's why we need to be very cautious. And your septicemia is, that's why it's what is called as, if you are, it's going to mask out your sepsis. Your sepsis finding, like steroids, the PPI doesn't going to show acute evidence of septicemia is there or not, because it's going to dampen your PAMP and DAMP. What is this PAMP and DAMP? Nothing but pathogen and damage associated molecular pattern. If it is going to get involved in that, you are not going to have all the classical findings. So that's why when you're going to use PPI, you need to be very, very cautious. And the duration always we need to recommend only for 8 weeks of therapy. That's all. And some patients we can try for 3 months of duration. And based upon the endoscopic severity, diet, lifestyle modification, we can wait, watch, counsel, reassess. No long duration of treatment is actually recommended, but certainly we are not following that. That has to be accepted. Even then, it's not approved.
The rampant use of NSAIDs. So what we get for, we get GERD or we get peptic ulcer or?
So
Because everybody has a
when
orthopedic problem and.
you are talking about NSAIDs, sir?
Yeah.
So when we are going to use NSAID for longer duration of time, there is high possibility for us to land with multiple complications. We may develop pancreatitis, we may develop peptic ulcer, we may develop evidence of severe erosive esophagitis. But among them, the NSAID which is going to high problem, high potency, high worsening will be predominantly be a diclofenac rather than considering a paracetamol other drug. So even then, by NSAIDs induced injury, we can try with the same PPI and other regimens.
What about tramadol?
Tramadol is, if you are going to use predominantly by IV formulation, when you are going to use by oral formulation, rather than considering diclofenac, the efficacy of tramadol to produce more GI injury will be slightly less.
This protein forming, as you said, for CKD, what should be the other alternative?
In CKD.
No, causes CKD like wrong use of protein pump inhibitors.
Prolonged use of proton pump inhibitor is always not recommended. So in that kind of scenario, always we need to go for H2 blockers. H2 blockers, there is no major adverse events except for few cases of hypertension, rarely few cases of headache and other things being reported, and no major cardiac events or no major side effects are going to be there. Only thing, the response will be around 50 to 60%. But if the patient is going to have evidence of C and D esophagitis, the response definitely is not going to be there much. But at that point of juncture, we can treat now with the probiotic role has been taken over in much in the field. Lactobacillus rhamnosus, Lactobacillus reuteri, GG and other components have been there when you're going to treat with H. pylori. That are also a separate area to be addressed here, but I didn't talk into the discussion. But these are all the things we can give as a supplementary role when you're going to manage based upon your trial and experience what you're going to face.
Commercially, alkaline water is available. Therefore, commercially, alkaline water is available now.
Commercial alkaline bottle is one of the worst thing to manage a patient, sir. That's why when you're going to see a gastroenterology prescription, if you're going to use, that's not the main line of molecule to treat, because the effect is only going to be short lasting 4 to 6 hours. There are so many things. Isolate preparation to some extent is well approved by FDA, but 4 to 6 hours of action. But apart from that, other components not much of beneficial role. And we use list of constipation, diarrhea, GA symptoms, bloatedness, all these things can be reported, sir. If there is no further questions, shall we wind up the session, sir?